Good morning, everyone. I'm Neil Love from Research to Practice, and welcome back to our National General Medical Oncology Summit. So we'll be going all day today, and then tomorrow morning with all the modules having a very similar format. And all of these modules will have members from the Florida Cancer Specialists as co-moderators, starting out with Dr. Zelenetz Lamar from Naples, Florida, at the far end here of the podium, and she will be bringing up questions and cases from her practice, as all the co-moderators are. And as we talked about last night in our keynote session, and here are the co-moderators for today, the other co-moderators from the FCS. And here's our schedule for today. We're going to start out talking about lymphomas, take a break, and then we'll talk about gynecologic cancers, and then go back to breast cancer from last night. Lunch, and then GU cancers in the afternoon, another break, followed by lung cancer. Tomorrow, again, we'll pick up with a bunch of other cancers. Really an incredible privilege to be able to spend this time with these elite investigators here today. As we've been talking about, of course, we will be talking about unapproved indications. Please consult the package inserts for all the agents, particularly the new agents that we're going to talk about. So we're going to start out talking about Hodgkin, non-Hodgkin lymphoma. In a second, I'll ask Nate Walker, the CEO of Florida Cancer Specialists, to come here to the stage and welcome you. But Nate, as you know, our work differentiates itself. We're very inquisitive. We like to pull out the content from investigators. We're just not asking you what you think we should know. We want to ask you what we want to know. And so we put together a series of videos just to remind ourselves that we're really here to ask you some tough questions. Here's our first one.
Yeah, it's a really good question.
That's a good question. It's a great question.
Yeah, so I think that's a very good question. I don't think anyone's got a straight answer.
That's a great question, Neil.
That's actually a really good question.
Great question.
It's a great question. It's something that we as a field are still kind of chewing on.
Yeah, great question.
I do think that's a good question.
That's an excellent question.
So that's an interesting question.
Yeah, I think this is a very interesting question.
So we want to challenge you here today. Okay, lymphomas, and Zelenetz, Zelenetz presented tons of cases. We were mentioning how many cases we've been presenting since the pandemic. I mean, you must have presented 20, 30 cases over the years, and some pretty good lymphoma ones. We might bring up a couple, but we're going to start out talking about follicular lymphoma, mantle cell, a lot of interesting things going there. Hodgkin lymphoma, wow, the big phase 3 trial, and lots of stuff going on in terms of CAR T, bispecifics, et cetera. We're going to start out with talking about follicular lymphoma. Before we get started, just sort of to preface this, from your perspective, Zelenetz, what are some of the things you think the general medical oncologists want to know about in terms of follicular lymphoma?
Well, I think we have a good idea of when to treat. The bigger question is what to use, especially in some of our Florida patients. Sometimes we have older patients, and trying to balance toxicity from therapy, especially in the later line settings, it can be very tricky for a community oncologist.
I'm curious, we asked, preliminarily, we asked the co-moderators to send in a bunch of questions, and one of the things you brought up, Zelenetz, that everybody brings up is the issue of bispecifics and CAR T, because these are two of the newest things. Andy's going to talk about that, and we're going to talk about that all morning in general. Anything specific, and have you actually been able to give a bispecific like mosunetuzumab yet for follicular lymphoma?
I have not, and I'm very interested in learning more, not only about toxicity, but things to look out for, and really what to expect.
So I'm kind of curious in terms of kind of where you see things coming in terms of follicular lymphoma. In the past, we had a lot of debates about first-line therapy, maintenance therapy. Where do we stand on that issue today? And also, having gone through COVID, particularly in terms of anti-CD20 therapy, having gone through that, are we less aggressive with that or not?
Yeah, I mean, I think it's something we still think about a lot. I think we're going to see the bispecifics move up front, given how well they, the efficacy is amazing. But giving very prolonged courses, we do see COVID. We've got a number of clinical trials even in patients who've never had therapy before. So I think time limited, really paying attention to the toxicity is going to be important, but the responses are really extraordinary.
Cami, one of the big questions that have been out there in terms of bispecifics is like who's going to give it and whether community-based general medical oncologists, what their role is going to be in that. Where do you see that now? Where do you see that heading, particularly with better tolerated agents like mosunetuzumab?
So right now we see still a lot of patients referred for these agents, but I do think that eventually they'll be able to easily move into the community. I think there'll be a transition from referral to us starting them and then transitioning back to the community after that first few months of high-risk period of cytokine release. But I think that these will, they're available in multiple myeloma, lymphoma, and probably more to come.
Who are in terms of the tertiary center that you deal with in terms of CAR T, bispecifics, and you're in Naples in West Florida, who are you dealing with?
Sure, primarily Moffitt. Yeah, primarily Moffitt. They have a satellite center now in Fort Lauderdale.
And have you, theoretically, are you set up to do what they've been talking about, maybe start therapy at, the tertiary center and then pick it up in your place?
Sure, so we're working hard towards that. Right now, there are still some things that need to be worked out. There is a center about an hour and a half away that we're working with in Sarasota to be able to try to make sure that once these patients are started on BiTE therapy, they can continue therapy at least a little bit closer to home.
Andy?
Well, so one of the problems with this, we start at the tertiary and then go home, is, and this happened with venetoclax in CLL, is patients got referred and then they said, why am I going back?
Right.
They couldn't do the treatment. I'm staying here. And we've actually gotten a lot of very bad blood from our community doctors because the patients vote with their feet and they don't go back, even though we you can go back. This is standard treatment, and they won't. So it's really important that people embrace and learn how to use these treatments in their practice and not depend on us to start it for them.
Matt?
I think the other part of this is actually insurance approval. So if you start in the academic center with insurance approval and then you say, okay, we gave the step-up dosing here, now let's transition. You need to start that process at cycle 1, day 1. Having that discussion and really working through the insurance process because you don't want to get stuck, right, with the same comment like, well, we're ready to send you back, but the facility that we're trying to get you to isn't prepared. They're not that you're not prepared to deliver it because the toxicity profile does get better, but you can't because of the insurance barriers of onboarding and dual approval.
Andy, I know you're going to talk about some of the data, but for practical purposes, what do you say to a patient who's about to start mosunetuzumab or, a bispecific for follicular lymphoma? And do you need to have tocilizumab available, incidentally?
So you do need tocilizumab available. Fortunately, with mosunetuzumab, it mostly sits in the pharmacy, which is a good thing. Not so much so with Epcor, and we certainly do see cases of CRS, grade 2 CRS that require us to use TOCI. And so yes, centers have to be trained, they have to be prepared to do it, and they have to have the drug available. And it's yet another expensive drug to have on the shelf so that you can treat patients.
And what do you say to patients? How do you prepare them who are going to get bispecifics? And one thing that's been kind of hard for me to tease out, and we're going to get into this with myeloma also, in terms of cellular approaches in general, whether it's bispecifics or CAR T, is infection risk.
Yeah.
What kind of infection risk, what you do prophylactically. I kind of get the feeling that maybe this is a pretty big problem, but you tell me.
It is a big problem, and I think one of the key parts is educating the patients that they need to call, because I think some of our more stoic New Englanders, they're sitting at home with fevers, and we really need to know that so we can assess them early. So there's a lot of education and coordination with our whole team. we see a lot of viral infections, and acyclovir can help for HSV and VZV, but is not going to help for. I have a patient who cannot clear rhinovirus who's on one of these bispecifics, and he's becoming repeatedly neutropenic, and I suspect the virus that he can't clear is probably contributing to that. So I think it's a lot of patient education. I will say for providers, there's just a paper that came out in Blood, a consensus statement on how they have beautiful tables on the different agents, the dosing, which is confusing, and the supportive care. And I think we're going to see a move towards more steroids and less tocilizumab, because I think a lot of these patients don't actually need tocilizumab, but we get nervous and we need to have it because of our experience with CAR T. We've seen some really high-grade things that we don't. I agree, mosunetuzumab is pretty straightforward. It's EPCO and glofitamab. And do we need to bring everyone in the hospital? That's the other barrier, is finding a hospital bed to bring people in, and we get these referrals in for people to step up the dosing, and we don't have the hospital beds.
Mm-hmm. Cami, I've heard stories too of people who give patients steroids to take home and say, call me if you have a fever, and, we'll treat over the phone. Is that kind of where we're moving more towards a more outpatient approach, a more community-based approach with these agents? Sub-Q now is coming on board.
Yeah, so we actually do provide patients with steroids, but ask them to call so we can instruct them whether or not to tell them. And when they're coming in, right now we still bring patients in with a fever because I don't think we know which way it's going to go. But as we get more experience, I do think it'll be easier to say. There are patients that can be managed at home, closely observed, and with strict instructions of when to come in if getting worse.
So, Zelenetz, any thoughts or questions?
Sure. So how do you choose between CAR T and BITE? When we refer to tertiary centers, patients often want to know what to expect from the conversation. So how are you making that distinction?
So Matt, maybe you can sort of tackle that. And again, now we're talking about follicular lymphoma. We get to diffuse large B-cell, mantle cell maybe, but now we're talking about follicular.
Yeah, I think that was going to be my next question, is what disease we're talking about. Because I think the answer changes depending upon follicular lymphoma and large cell lymphoma. In follicular lymphoma, I've already started the discussion at the second line therapy, talking to them about bispecific therapies, because we know that second-line therapy, works well, but it doesn't work well in everybody. In those patients that it isn't working well, and then transitioning to mosunetuzumab, I think is important. So I've reserved CAR T-cell after. That may change as the cellular therapy landscape changes with what's approved in relapsed refractory follicular lymphoma from your treatment options. I think large cell lymphoma, it's a little bit inverted from that standpoint, where I use CAR T-cell first, bispecifics following.
So we're going to let Andy go through some of the data, maybe come back to this, give the audience a chance to think whether they have any questions, and Etta to think about some questions about follicular. But Andy, let's take a look at the data.
Well, so this discussion has been a great setup for this case. I'm an equal opportunity consultant. Perfect setup for this case. This was a 76-year-old man who had multiple recurrent follicular lymphoma. Note, he originally presented in September of 2012. That is not a typo. It's not 2022. It's 2012, 12 years ago, okay? So started with stage 1E disease and got rituximab, then progressed. There was evidence of transformation to large cell, got R-CHOP, did very well. His large cell lymphoma went into remission. He recurred as follicular lymphoma. He got rituximab lenalidomide with less than a PR. He got obinutuzumab bendamustine with a complete response. But that was relatively short-lived, and he went on to receive mosunetuzumab.
Before you go on, Andy, just to pick up on one maybe teaching point, maybe Ann, you can comment on this, but this thing of going back and forth between FL and diffuse large B-cell, and trying to figure out whether or not somebody really has FL or a transformed disease. Any comments on that?
Yeah, I think you have to have a low threshold to rebiopsy people, and we use the PET to guide, the hottest area we would try to rebiopsy. Sometimes you can't rebiopsy, and I think you have to use your best clinical judgment. And I think up front, if you're worried about transformation, I think you have to treat for transformed disease.
So like Andy, when you look at this patient, do you visualize like two different clones, a diffuse large B cell and a follicular clone?
So molecularly, we know that there's a common progenitor cell that is then giving rise, and sometimes we can say that it's actually an earlier cell, sometimes it's a later cell. There are some clones that absolutely unequivocally arise from the follicular lymphoma. We know that from DNA sequencing, but some of these clones actually are arising from a common progenitor clone that, it's simply there. And, it's one of the oddities that particularly when it's early in the course, and patients have had minimal prior treatment, maybe rituximab, maybe nothing, maybe some radiation, their outcome for their large cell lymphoma is equivalent to de novo large cell lymphoma. And it's bizarre. Here you have an incurable underlying disease, you give them their R-CHOP, and you cure a lot of them from their transformed disease, and like this patient, they come back as follicular lymphoma.
Zanetta?
Yeah, so what SUV on PET are you using to distinguish between, a low-grade lymphoma and whether or not it's transformed?
Cami?
So I guess I don't use a standard cutoff, but usually I think of an SUV at 20 or higher is not going to be likely to be, is more likely to be aggressive. I also look at it if there's an SUV out of proportion to other SUVs. So if I have something that's, 4, 5, 6, and then something that's 15, I'm biopsying that lesion that's 15.
One of the things you can't see in audio is when everybody goes like this.
We actually use that as a teaching point to our fellows. I call it the Sesame Street lymph node, right? Which one of these are not like the other? And that actually resonates with them, because that, I think, is an important, when you're talking about where to go biopsy, right? From that standpoint, to guide the next therapy.
All right, so the patient got mosunetuzumab. How did the patient do, and any CRS? What happened?
So the patient actually tolerated it great. Had a very mild fever the first evening, took Tylenol, nothing else, and no other CRS. Almost no ICANS with mosunetuzumab. It's incredibly rare.
Neurologic complication.
And so completed step-up dosing. Had only a PR after 8 cycles. We continued to 17 cycles. And I will show, if you're at a PR, the handwriting's on the wall. And I'll show you some data about that, particularly with Epcor, but it's true with Mosun as well. And so the patient had progression at the end of 17 cycles and is now referred for CAR T-cell. So one of the questions is, was the sequencing appropriate? Should have I done bispecific first and then, or should I have done CAR T first? And I actually think that this was the right sequence, even though it didn't work for him. And though I could give you a different case, and I actually had it in there, but it was over the 8 minutes, of someone who I would have chosen for CAR T first. And that's a patient who, gets very aggressive first-line treatment like R-CHOP and then blows through it within 6 months. Don't bother with the bispecifics, just go to CAR T.
What happened?
That patient is alive and well and lives in Seoul and is doing great, actually.
This patient here?
No, the one who blew through R-CHOP.
How about this one?
He's literally in the mix. We just referred him for CAR T cells.
Interesting. Which one?
He's going to get Tisagen-Leclucel. He's a little old for axicabtagene. We would really like to give him lisacabtagene, Marilucel, but he's not gonna make it in time for the approval. So today I really want to focus on immunotherapy, and we have a lot of treatments available for us at relapse. Obviously, this is a disease where there is no absolute right answer all the time, and you can see from this patient's history dating back 12 years that, different things happen during the course of treatment, and you really have to individualize therapy. So, sometimes it's completely appropriate to go back to your alkylator-based therapy if they had a, very long remission duration that, was 8 or 9 years, you could go back to, rituximab and CVP, and that would be a reasonable treatment option. I think the role of high-dose therapy in autologous stem cell transplant and allotransplant is a little bit more difficult to define in the current era, but we do have these new immunotherapies that have been approved, and there are a bunch of immunotherapies that are on the horizon. So I really want to focus on the T-cell engagers or bispecific antibodies. Why do I say T-cell engagers and not bispecifics? Because we have bispecifics, trispecifics, and now tetraspecifics. And it's really all about antibody engineering and how many targets you hit. And are you trying to hit 2 targets on the lymphoma and 1 target on the effector cells, or 2 targets on the effector cells and 1 target on the lymphoma? All about engineering and what's going to be better, and then as well as CAR T cells. So these are the approved CAR T cells, axicabtagene ciloleucel and Tgen-leclucel. The axicabtagene ciloleucel study included both follicular lymphoma and marginal zone lymphoma. Just one quick comment on marginal zone lymphoma. When this was originally presented, it looked like this treatment did not work for marginal zone lymphoma, but with longer follow-up, the results in marginal zone lymphoma actually look quite good. Overall response rates with both of these agents is really high, but we don't really care about response, we care about durability. Thus far, the results are durable, but this is follicular lymphoma. So, if you're large cell lymphoma and you get to 2 years, you know that the risk of recurrence is extremely low. But in follicular lymphoma, we know that recurrences can happen late. And so we actually keep coming back to the same question. Whenever we're asked, like, well, we would really like to know the durability. Are these really durable responses? There was a really interesting update at ASH of the axicabtagene ciloleucel study, and that's shown here, and I apologize, it's a little crammed down in the slide, but what it is, it's time from bendamustine to CAR T cell and the result. And so you can see, if it's less than 6 months, you don't have good T cells and it simply does not work. If you've never gotten bendamustine, you do the best. This curve here is more than 12 months since you've got bendamustine. Bendamustine destroys T cells. It really impacts both bispecifics and CAR T cells. I personally do not use it. Yes, I know this patient got it, but I don't use it anymore. And no patient of mine with follicular lymphoma gets bendamustine. And that was even before these data were available. These immunotherapies are important therapies, and bendamustine is a great immunotherapy killer. These are approved. It's not yet approved for marginal zone, but it is NCCN listed. We have a number of bispecifics. The only one approved in the space so far is mosunetuzumab. These are all phase 2 studies. Overall response rates are really quite similar, around 80%. Complete response rates range from 60 to 75%. Median PFS is about 1.5 years, and with Mosun, this is time-limited therapy. This is incredibly well-tolerated treatment. The risk of grade 3 CRS is a good approximation of 0. There is some grade 2. The key is to educate the patients really well. Make sure that they're calling when they're having that fever or a little bit of a chill. Intervening early with acetaminophen and steroids often will eliminate the need for TOSI. I've given a commercial drug to probably 30 patients now, maybe 25, and I've given TOSI once. So, okay. So this is the thing that's coming to your clinic soon, and this is epcoritamab. This was the NHL-1 study. There was a follicular lymphoma cohort. These are the patients, 128 patients, largely advanced stage disease, with 40% of patients having, 31% of patients having 4 or more lines of prior therapy. Here are the results. This is the duration of response and duration of CR. And you can see that responses occur across different risk groups, including POD24, though don't get me started on that. That is no longer a useful thing. But the double refractory, that is useful, and refractory to prior treatment, and these drugs work in all of these risk groups. Overall survival is excellent, but as I pointed out earlier, it really matters if you respond. And that's why I said, you know, he was a PR after 8 months. I probably could have just thrown in the towel and said, gee, it's time to move on, because it's the CRs that have really durable responses, and CRs occur early. Late CRs, in my opinion, are really quite unusual. CRS is the most common event, but it's mostly grade 1-2. With epcoritamab, the risk of CRS is greater than with Mosun. If you optimize the cycle 1 step-up dosing using more steroids, you can dramatically reduce the CRS, and that is the recommended approach these days. There were no cases of ICANS with cycle 1 optimization. This is the pivotal study that is going to get full approval for epcoritamab in relapsed refractory follicular lymphoma. It's rituximab lenalidomide, the approved second-line treatment, compared to epcoritamab plus rituximab plus lenalidomide. You might want to ask some questions about, does this trial make sense? Because why is the rituximab there? I can't answer the question, so someone else will have to answer it for me, because it makes no sense to me. So what about CAR T cells? So we have Tzigenlecleucel approved. That's gentle, it's easy, but it might go away. Axicabtagene is a really good drug, but it really can be tough on some people. Lisacabtagene maraleucel is a better tolerated CAR T cell, and this was an updated analysis of the Transcend Follicular Lymphoma study that was presented at ASH. It really emphasized use in second line compared to third line plus, but I'm not entirely sure that they made their point. These are the progression-free survival curves, and they're the same between second line and third line plus. So you might argue that, oh, gee, then I should use it in second line. But there are long-term consequences of this treatment, and if it works really well in third line, except in very selected patients, you're going to use it in later lines of treatment. This is a little bit more toxic than mosunetuzumab and even epcoritamab. There is a lot of neutropenia associated with this, but we do also see substantial CRS that is it's mild to moderate, but unlike the bispecifics where you can send someone home tell them to buy some Tylenol and send them with some dexamethasone, you have to be really prepared to give tocilizumab to these patients. So I just want to mention one thing, and that is because there was maybe what was surprising to some people, the approval of zanubrutinib in relapsed refractory follicular lymphoma. Zanubrutinib was not approved in relapsed refractory follicular lymphoma. Obinutuzumab plus zanubrutinib was approved in relapsed refractory follicular lymphoma. Single agent zanubrutinib does not have wonderful activity, similar to prior studies with ibrutinib. However, in this randomized study, the Rosewood study, it compared obinutuzumab monotherapy to obinutuzumab plus zanubrutinib, and there were major differences in both duration of response and progression-free survival. This is actually a pretty well-tolerated treatment. You can see that the AE profile is not all that different by adding zanubrutinib to the obinutuzumab. So this is an option for your patients with relapsed refractory disease. It's gentle. Zanubrutinib is a very well-tolerated BTK inhibitor. So with that, I will stop.
So we're going to move on to mantle cell, but just to follow up, because I felt like I missed this day in school, like BTK and follicular lymphoma. Is this like some theoretical synergy or something, Andy, that doesn't have single agent, but somehow it enhances like what's the idea behind it? And is this something you think you're going to use?
I think there are certainly selected circumstances where I would use it. It's efficacious, and it has a very favorable side effect profile. The BTK inhibitors, we thought actually should be great drugs. In theory, they have the right pathway, everything else. The early data, when we did the phase 1 of ibrutinib, the highest response rates were in follicular lymphoma of the relapsed refractory cases. And then we did dedicated studies, and there was Nancy Bartlett's study, which was a community study with a miserable response rate. And then the company did a study, and it was more miserable. And so okay, BTK inhibitors don't work. Zanubrutinib does have a somewhat higher response rate than ibrutinib does, but the combination is clearly different than the monotherapy. Why exactly that is? It's a little bit tricky because zanubrutinib is hitting the B-cell receptor downstream, and CD20 is actually a different pathway. But it might be that by hitting both of those pathways, there's some synergy. And we need to do a little bit more laboratory work to understand that.
All right, well, we could talk about this for a while, but let's move on to mantle cell. And Matt, I want you to listen to a case. I was mentioning that Zelenetz presented so many cases and every possible tumor. We call her up and say, hey, can you present a few cases of myelofibrosis this afternoon? We have a conference tomorrow. But in any event, this is one of my favorites that I heard. This is a patient who was taken care of who had no insurance, right, with mantle cell that she's fighting to try to find something. And when she presented the case, I just spent a couple hours with Dr. Wang from MD Anderson as a preface for that, and I was like, whoa, because we'll talk a little bit about some of the things that he's been talking about. But Zelenetz, can you kind of summarize what happened with this man?
I'll make it very, very quick if I can. So this is a 50-ish-year-old gentleman who actually was admitted to the hospital after complications from an inebriated event that ended up with some broken bones, and he was incidentally found to have mantle cell lymphoma, diffuse adenopathy, pancytopenia, and he was actually diagnosed with blastic mantle cell lymphoma. I think one of the questions that I have proposed about him is, what do we do for induction therapy, especially in a gentleman without insurance? And so what I did, I begged, and we were able to get him zanubrutinib, and he had a really nice response.
And you got him rituximab too, right?
Yeah, we gave him some rituximab with it, yes. And so he had a really nice response, was doing well, got off the sauce, and he relapsed. And so we still have a bit of an insurance issue. I got him to a tertiary center. They said, hey, why don't you try pirtobrutinib while we figure something out? Started him on pirtobrutinib. some response, but not very long. And so actually through divine intervention, and I still don't know why, and I'm almost afraid to say it, we were able to get him some insurance, and he is about to go to CAR T-cell.
So to me, I hadn't heard, the last I heard, he was responding to zanubrutuximab, which was, like I said, I just heard this whole story from Michael Wong, but I hadn't heard that he got, how did he, any tolerance problem with the pirtobrutinib?
No, he did really well.
Any thoughts about what you just heard, Matt?
Yeah, it's almost analogous to the case that I'm going to present, because I think we're all struggling, with a younger population, that has blastoid variant type morphology. One thing that I didn't hear though, which is I think a resounding theme in mantle cell lymphoma, is what was their TP53 mutational status?
Positive.
Positive,
He was
exactly.
TP53
So,
positive.
yes. We are starting to know that you only can say if you're TP53 mutant or not if you check for it, right? And we see it in about 10% of mantle cell lymphomas, but you see it in 0% if you don't test for it. And I think that now, as things are shifting, as my prior slide was trying to be a little bit thematic around the triangle trial, talking about just how things are shifting, but not all shapes are the same. In even our uncommon diseases like mantle cell lymphoma, age matters. Your symptoms burden. This was found incidentally. You can still observe mantle cell lymphoma if the patient is asymptomatic, and that durability of being observed can last for months, if not years, from that standpoint. So I'm going to go ahead.
Yeah. Before you kind of get to your case, and I'll just maybe pick the brain a little bit more of the faculty in terms of these issues in terms of mantle cell, and as we're talking about, incidentally, our next session after this is gynecologic cancers. We just read SGO here, and P53 is like a huge thing we're about to talk about, endometrial cancer. So it's interesting what the general medical oncologist is hearing from different people. But Cami, I'm just kind of curious, before we kind of get into these cases, how are you thinking through first-line therapy nowadays? And to me, I'm seeing BTK being talked about, not so much about the way it was used like in the triangle trial, but the way Zelenetz patient just got, anti-CD20, BTK, venetoclax also we're hearing about even up front. Before we start looking at the data, do you see things shifting more in that direction towards, again, BTK earlier and maybe even venetoclax?
Yeah, I do. I think that there's been enough trials and data showing that patients definitely benefit from BTK inhibitors in the first-line setting. I think it's still unclear in what combinations or what role in all patients that benefit is provided. I think in patients with high-risk disease, like the TP53 mutated, and in older patients, thinking about BTK combinations that are BTK with CD20 or BTK CD20, maybe venetoclax, to induce a remission. And then I still think probably in younger patients who don't have TP53 mutated disease, a triangle-like approach where maybe you do give them some chemotherapy with BTK maintenance.
Andy, I see you have a comment, but also I'm curious how you think the recurrent mantle cell, again, in a case like this, where pirtobrutinib fits in, to use other bridging therapies to CAR T. What kind of condition does a patient with mantle cell need to be in to go to CAR T?
So I certainly like the idea of extending the benefit of the BTK inhibitors, but pirtobrutinib in mantle cell lymphoma is not quite as good as pirtobrutinib in relapsed refractory CLL. Even though the approval was first in mantle cell, it should have been first in CLL because that's actually where it is a bit better drug. So you don't get that much mileage out of it. But sometimes you get enough to get them to CAR T cells. So sometimes you can bridge people with Pirto to the CAR T cell. And as I mentioned, there are better and worse CAR T cells. Lisacaptagene maraleucel has really outstanding results in mantle cell lymphoma. These have been published.
I think I had a case that I did a video with you. We presented it at ASH. I think it was like an 87-year-old woman.
Correct.
Who cruised right through.
She was mostly mantle cell lymphoma when we treated her, and she remains NED today. It is a well-tolerated drug, much better tolerated than axicabtagene, because you can't treat an older patient. Now, how old was this patient?
He was 55.
Yeah, so I mean, he could easily get axicabtagene, no problem.
So, Matt, what about your 61-year-old man here? He's a cattleman?
Yeah, I was watching a little Yellowstone when I probably talked about this case here because we're entering into calving season. But I think it also gets into the approach of, sometimes your patients don't live next door to the cancer center, and so you have to take that into consideration also, and also how they present. This gentleman, thought he had an inguinal hernia, right, that he just couldn't reduce and was walking around with this for several months, right? So to get a rancher to actually come into the doctor means that there's something really wrong. From that standpoint, I'm actually was impressed that they had he had a past medical history, to boot here with hypertension, diabetes, and hyperlipidemia. Whether or not they were taking that medicine, is a different question. So physical exam matters, but also the history matters in this patient. They were still out doing their role on their ranch. But labs showed a normocytic anemia. LDH was elevated. I think the clear issue here is we've seen a culture of IR-guided biopsies, and I think in lymphoma it's incredibly important to do excisional biopsies to help render an appropriate diagnosis. But also as we move into kind of more the molecular landscape, having the tissue available to do it matters. And so many times with these IR-guided biopsies, the tissue is exhausted, especially when you're talking about less common non-Hodgkin's lymphomas that require not only primary, secondary, tertiary, quaternary stains to actually make the diagnosis. You can see here the standard immunohistochemistry panel listed for this patient. I will call out that the Ki-67 was high. 50% is abnormally high for mantle cell lymphoma, and I think that portends potentially a more aggressive mantle cell lymphoma. Had the standard translocations for 11-14, but notably here the deletion 17p was not seen on FISH. But with molecular testing, the TP53 mutation was seen. That can happen. It's not very common, but it can. So just because you don't see deletion 17p does not mean that the TP53 mutation is not present. Commonly in mantle cell lymphoma presents an advanced stage disease. You can see in this gentleman he had both cervical palpable adenopathy, but also disease that you couldn't palpate. Commonly, bone marrow involvement is seen with mantle cell lymphoma. It may have been driving the normocytic anemia, but also can in a pro-inflammatory state from that standpoint. He had no GI issues, so I don't typically do colonoscopies to look for lymphomatoid papulosis from that standpoint, unless they're having GI symptoms. But it's not uncommon, maybe once, twice a year, I get a colonoscopy incidental finding of mantle cell lymphoma only at the time of colonoscopy. Next slide. Oh, I can do it myself. I'm talking to myself. I feel like I'm Bill Murray in Lost in Translation. I came from Tokyo yesterday, so I'm kind of swimming up here. So anyways, my impression was that this is a stage 4A TP53 mutated mantle cell lymphoma. I do the biologic MIPI or the MIPI on all my mantle cell lymphoma patients. Why? Not that because I utilize it in my clinical practice, but I was a fellow once, and if I'm doing retrospective reviews, I really respect the clinician that helps me out in doing my data reviews. I learned that from this guy right here. So
before you go on, how did you treat the patient?
Well, it's an interesting scenario, one that we're seeing more and more often in academia because the community is testing for TP53 mutation, and they're kind of punting the decision on what to do. Sometimes they come at you already on bendamustine rituximab, and so then you have to kind of navigate those waters. So I think it's if you're making the decision on frontline therapy, I will try to get a BTK first, a BTK plus CD20, and then the question is do you add venetoclax to that? I'm going to talk about the Bovin trial, which I think is really impressive data, and I wish that it lived in some compendium listing somewhere so that I could have better access to it. Maybe in the future that will happen. But if I can't, then it truly is where do you dip your toe in the water of how much therapy? And that's why the disease guides you down kind of how much you have to give them. I'm very curious that your patient responded with blastoid morphology, because often in my practice, if I see that, I'm less confident that a BTK alone is going to be able to pull the reins back on this disease, and I may need to control it with some sort of an anthracycline-based approach, or even bendamustine, understanding that some people won't give bendamustine anymore because they believe that it sets the clone on fire, right? And that's driving a more potentially aggressive process. I think this slide just alludes to is that there's many different types of mantle cell lymphoma. Mantle cell lymphoma is not one disease, and we continue to learn just how, even though it was shrouded in the mystery of CLL, it still remains shrouded in the molecular studies now, but we're uncovering, different variants of mantle cell lymphoma. I alluded to this earlier, TP3 mutation is bad in mantle cell lymphoma. I don't think that bad blood, I'll just say it again, this is a problem when you find this, because what had the Europeans tried to do? They tried to give the kitchen sink approach, and they found out in this patient population, heavy hitting induction therapy followed by consolidative auto transplant in this population does not do well. In fact, I will counsel the patients early on, about I'm probably not going to consolidate you with an autologous transplant if I see a TP3 mutation present, but often it's not been tested at the time that I'm seeing them for consultation. But most people give BR, and I think that it's a reflexive approach, because BR, quote unquote, is something that you can give every 28 days. You can give it in a 30-year-old. You can probably give it in an 80-year-old. But it's not necessarily what during the response of BR. I think some of the problems with BR is what happens after you give the BR. Prolonged cytopenias, prolonged infections, recurrent infections, inability to get rid of those infections. And so while it controls the disease and you can have long-term durable remissions, don't forget, I don't stop the acyclovir for fear of zoster anytime after giving BR. This is the first time that I've given a mantle cell lymphoma talk, and I'm going to timestamp this talk, where I'm not going to talk about the I word, right? The I word is not in this talk, and we're moved on to second-generation BTK inhibitors with zanubrutinib and acalabrutinib in mantle cell lymphoma. We've already heard about pirtobrutinib and where to position pirtobrutinib, and I really don't think that we know yet, and prospective clinical trials are going to help answer that question. Not everybody dies quickly with mantle cell lymphoma, and I think that you can see in the BTK era, we are making progress. Is that progress substantial? But it is by decade also. You can see here that we are slowly improving each decade with regards to the BTK era and the access to BTK. But when do you need the BTK, I think is an important question in mantle cell lymphoma treatment landscape. There are a lot of emerging trials here. You can see the ECHO trial, which is bendamustine based. So you can see acalabrutinib plus bendamustine rituximab versus bendamustine rituximab placebo. We're also seeing non-bendamustine approaches, right? This is really putting your money where your mouth is in the Mangrove trial, right? Really going mano-a-mano against BR with zanubrutinib rituximab in a frontline trial. You can see the patient population, though, that is being tested. So again, appropriate, but we'll see what these prospective trials demonstrate to us. This is a trial that I'm looking most forward to. I think this was a very nice trial to kind of roll people into transplant, no transplant discussions. This is the ECOG 4181. It then allowed for ECOG 8151, which was a transplant, no transplant, based upon MRD assessment. You can see that this incorporates some people's favorite drug of cytarabine for mantle cell lymphoma, using it in a sequential approach of BR followed by cytarabine, or adding a second-generation BTK like acalabrutinib BR. The one that I was hoping was going to win was acalabrutinib plus BR, but this arm was stopped early. Not because of toxicity or not because it wasn't efficacious, but because it didn't meet the efficacy threshold to be superior than the other two arms, which I thought was a little bit of a unique trial design. So haven't seen any data on this, but this is likely data that's going to be interesting coming into the future. I already alluded to the bovine trial. I don't know why I decided to not capitalize the E and the N here.
That's correct.
Oh, it is?
Yes.
No. I thought it went along with my calving discussion of like bovine. I always think of bovine here, but anyway, so this is zanubrutinib, obinutuzumab, lead-in. Right, you can see the schema here, and this is for TP53 mutated mantle cell lymphoma. There are multiple cohorts to this study. This is looking at the TP53 mutated untreated population. I think at the time of the presentation it was 25 patients. Interestingly, with just zanubrutinib, obinutuzumab alone, over 60% of the patients, by the time before they were going to get the venetoclax, had already gotten into a complete response. I believe it was like 68%. You add the venetoclax to it, you jump that CR rate up to 88%. Again, so you have a well-tolerated BTK, you're utilizing arguably a very strong CD20, and then adding where I think the BCL2 inhibitor matters, right? By itself in mantle cell lymphoma, together, yay. All right, so I think that that's a lesson here. The next question becomes durability, and I think that this was longer follow-up and a prayer, we'll be able to start to use this in frontline mantle cell lymphoma, as you can see based upon the swimmer's plots here.
Incidentally, I noticed you ramp up the venetoclax. Do you see TLS?
I don't think in the trial there was a single case. There was one laboratory TLS, I think.
We actually had one case of grade 4 TLS, actually from the obinutuzumab and zanubrutinib, but there were only a couple of minor single laboratory abnormalities. Nothing met the Bishop Cairo definition of laboratory CRS, but this trial would have not happened if I didn't ramp up. I begged not to ramp up, but they said no.
Keep going.
All right. So here are some other trials. There is the I-word plus venetoclax. Hard to know, what the relevance is now and how you can switch out ibrutinib for acalabrutinib or zanubrutinib in this space. We're going to see prospective trials kind of mimicking this. This is the Simpatico trial, which was recently presented at ASH this year, showing a PFS advantage with the addition of venetoclax to ibrutinib. So what about acalabrutinib? You can see here, I'm just calling out because of the case. I didn't know you were going to present a similar case, but looking at kind of blastoid pleomorphic morphology. Here you can see that if you look at all patients versus this high-risk population, the CR rate was fairly similar. However, the median duration of response, I think, is really the key take-home point here, is that often the morphology or the aggressiveness of the disease matters. So if you see that, be thinking about what you're going to do next. And this isn't CLL. You have to discern if they're responding, and you have to continue to assure that they're responding, because if you're catching an asymptomatic relapse, that's the time to pivot to the next therapy, not when they're blowing through their covalent BTK. Zanubrutinib, you can see here also 86 patients, best response of 78% as a CR, long follow-up, median PFS 33 months. Again, different population here, but as you can see, if you can get them into a CR, those CRs can be durable. Andy went over on his time, so I am going to also, just slightly. But you can see here that zanubrutinib, you do see hematologic toxicities, infections, specifically viral infections, can be an issue. I often try to treat through until I see kind of that continuous symptoms lasting more than a week, and then I try to give them a hold. We heard about pirtobrutinib, our non-covalent BTK. You can see here, this is just from ASH of this year. For those who were intolerant and discontinued their prior BTK, good responses. You can see responses in those individuals who have progressed on their covalent BTK, but caution again, when you're using pirtobrutinib because or after a covalent BTK progression, expect to do something very soon. What is very soon? Within the next 6 to 12 months. In my practice, actually, I've started to use pirtobrutinib as a bridge to CAR T-cell. Right? You stop the BTK, 100% of the disease is progressing. You keep it going, 10% of the disease is progressing. This is like EGFR and lung cancer, right? That's probably 12, 13 years ago when we learned that lesson of not to stop your EGFR inhibitor. Do not stop your BTK inhibitor until you have a plan on what to do next. Good durability, if you can get them into a CR, from that standpoint, and a very well-tolerated drug from a BTK standpoint. But this, again, is in BTK-naive mantle cell lymphoma. I alluded to that there's prospective trials going head-to-head against covalent BTKs in the relapsed refractory mantle cell space.
What about safety of pirtobrutinib and your own experience?
Timing's impeccable here.
Yeah, there you go. But I'm also curious about your personal experience. Can you see a difference compared to the covalent?
When I've used pirtobrutinib, it has been a drug that you prescribe and they go home and they come back. You're they're actually asking you sometimes, am I getting the medicine? And you have to give them confidence, just like antihypertensives sometimes, that yes, it is working, except they can take their blood pressure, they can't do a home CAT scan.
So, and not any, cardiac signals?
I have not seen, a strong cardiac signal. In fact, this would be a population that I would be willing to use pirtobrutinib on. Atrial fibrillation, again, just like mantle cell lymphoma isn't one disease, AFib is not one disease. You have the AFib that winds up in the ER, and then you have the people that you're listening to them in the exam room, and you have to listen past 2 heartbeats, right, to hear AFib. But the patient knows when something's wrong because you left your stethoscope there, and you're like, oh man, now this is gonna kill my clinic. I gotta work up AFib in the clinic. Oh my gosh, here we go. Why did I listen for more than 2 heartbeats? No, I'm just kidding.
Okay, Brexucell.
Yes. So as I digress, or I did digress, but I'm going to jump back now to CAR T-cell because you now can't do a talk without talking about CAR T-cell in almost all non-Hodgkin's B-cell lymphomas. Brexucell, here you can see overall response rates 91%, CR rates 68%. Those CRs can be durable, right? But the durability is starting to wane. We are seeing late relapses with mantle cell lymphoma. So about the curative intent of this therapy remains in question. But again, I would allude to, you got to understand the disease. This is not follicular lymphoma. This is mantle cell lymphoma relapsing after a BTK, a very poor prognosis situation. So I actually think these curves are pretty darn good, for that patient population. We're going to see Liso-cel. I think you heard the Transcend follicular lymphoma. This is the Transcend MCL data. This was buried with the large cell lymphoma data set, so it's very convoluted in how it was reported. Just like the Transcend data set was mind-boggling, even to a person who was on the trial trying to interpret the publication to explain it to people. But I think you can see here 74 patients, a CR rate nearly 75%. I think here the question is going to be, again, durability, and will there be a plateau on this curve? I think that there is a palpable difference in the toxicity profile between Liso-cel, at least in the clinical trials, and what I've seen with Brexucell in not only in the commercial environment. So I'm hopeful that this will receive a label here later in the spring. I believe the PDUFA date's in May. And with that, I will end. Thank you.
So a couple of follow-up questions from the audience. Actually, Andy, a number of people, Julia, who's here in the room, and Albina, who's online, want you to clarify your comment about bendamustine and FL, and like what's your upfront therapy?
So if you look at the gallium study, there were premature deaths in the bendamustine-treated patients, both on the rituximab arm and the obinutuzumab arm. It did not impact the overall survival, but there were premature late deaths in these treatments, and it was related to bendamustine. Bendamustine results in long-term T-cell suppression. So I actually do not use bendamustine, rituximab, or bendamustine or obinutuzumab in first line. I use either obinutuzumab CVP, because that's almost indistinguishable, not rituximab CVP, that's inferior, clearly, or obinutuzumab and CHOP, but I've actually eliminated bendamustine entirely from my follicular lymphoma patients.
What about mantle cell?
So
I don't actually give bendamustine to my mantle cell patients either, because I have clinical trials.
all right, before we go too far out on the limb, also, Matt, Daniel wants to know whether you use MRD testing in mantle cell, which modality, flow or NGS, and how does it guide your decisions if you do use it?
I have not started to use it in induction therapy in mantle cell lymphoma. I do use it in the trial that I alluded to, which I think is the transplant, no transplant trial. That trial is taking the best of the best, right? Those patients that are MRD negative and PET negative, and asking the question, what does transplant bring to that population? I think transplant is already in question based upon the triangle data set, but again, that's inherent in bringing BTK up front in that population too. So outside of a clinical trial, I have not employed that into my practice. Large cell lymphoma, different discussion.
So I have to punish the two of you for going over, so no more. So let's go over to Hodgkin lymphoma, and I'm curious, Zanetta, you know, in terms of Hodgkin lymphoma, what a huge story we saw here in terms of, you know, adding IO. I guess the first thing I'm kind of curious about, Cami, is why did it take so long? I mean, we knew that Hodgkin lymphoma is so sensitive to checkpoint inhibitors. I've been waiting for a first-line trial. You know, we're going through, you know, all this stuff with the BV-AVD, and then boom, this comes along and sort of blows it away. Why did it, I mean, really, why did it take so long?
I mean, I think, you know, you had to do the randomized phase 3 trial, but really that trial enrolled very quickly and resulted very quickly. So if you look at it from the time point of, I mean, there was a lot of interest in incorporating IO, and I would say that that was a very, very quickly enrolled trial.
And also, I'm just kind of curious too, Ann, now that we see this activity, you know, checkpoint, you know, we've been talking for years in solid tumors about it, and one of the big issues in checkpoint is when do you think about not giving it because of prior autoimmune disease? I don't know how often you see that, particularly in younger patients, prior, you know, renal transplant. You do see older people. Have you run into situations where people had relative or absolute contraindication to IOs, and then what do you do?
You know, I think you sort of have to look at it on a patient-by-patient basis. And if people have really severe autoimmune disease and are requiring biologic therapy, you know, then that would give me pause. But when you give people chemotherapy plus IO, typically their rheumatoid arthritis or lupus is actually under good control with the addition of the chemotherapy. So I think it's going to be, you know, relatively infrequently that we need to hold it.
Curious to know, you know, kind of what your perspective has been, you know, sort of how you got the information. Have you had any patients? You know, you don't see, you know, Hodgkin every day in general medical practice. Have you actually done this yet, Zanetta?
I have not used Nivo AVD yet, but it's been coming up. I've been talking to other providers, and so it seems like it just landed in our lap out of the blue that, hey, we knew that we were dropping the bleo. We felt comfortable with that. We're like, great. And some people, you know, okay, brentuximab, AVD, okay. And then when Nivo AVD, it just kind of blew our mind a little bit. And now there are more questions, especially in older people. Okay, I think it's a little bit more clear, but what about in a younger person? You know, are we using BV-AVD versus Nivo-AVD? How do you think about that?
Andy, any thoughts in terms of who should not get Nivo-AVD? Is there any?
So Nivo AVD, because it's not NCCN listed, and it is actually cheaper than BV-AVD, which is sort of interesting, but it's not always easy to get. I have about a 40% hit rate with insurance companies. About 60% of the time I've been turned down. So it can be a little bit tricky to give. In terms of who not to give it to, I agree with Ann. I think the patients are pretty rare that you wouldn't give it to.
And then, Zanetta's question, we've seen these young people get cured for years and years. Are we really going to switch this therapy? Again, younger patients, Andy?
Well, so listen, I was a person who said you shouldn't give BV-AVD for just a progression-free survival difference, but the second that there was an overall survival difference, boom, there was. Now, right now, we only have a progression-free survival difference with Nivo, but it's better tolerated and it's cheaper. So we have a better tolerated and cheaper treatment. So to me, it's actually a pretty easy decision that should be the treatment, but unfortunately we don't have full access to it.
And again, before we take a look at the data, to come back to Matt, any practical considerations in terms of Nivo, AVD? I mean, again, this audience has used a ton of checkpoint inhibitors, but not in this situation.
So this is Michael Jordan from the free throw line, slam dunk in people over the age of 60. I think it's then if you migrate down by decade, I think as you start to get into the era of individuals who have fertility questions, I think the fertility questions with checkpoint inhibitors are relevant in this population. You have good data with ABVD, and you actually have very good data with BV-AVD coming out of the Echelon 1 trial around pregnancy, fertility from that standpoint. If you look at the checkpoint data literature on fertility, it's fairly limited from that standpoint. And so if you're handing this off to a 18 to 28-year-old, I don't know how to have that discussion other than having it in the setting of a prospective clinical trial. I think we're going to see more data on this, obviously, but it's still cooking. That's an interesting perspective, though, particularly in terms of the efficacy difference. Would you, I don't remember hearing about infertility, and of course, obviously I have older patients with solid tumors, but theoretically, would you expect an IO to affect fertility? I think you can see a certain ovarian suppression
really?
From that standpoint.
Yeah.
Both central, if you get hypopit, you could get it on that basis, or a direct effect. There have been some case reports, but I totally agree. It gives me a little bit of pause. And generally, we don't send people for fertility preservation before they start therapy for Hodgkin with BV-AVD or ABVD. But if you're going to use this, it's something that we talk to patients about.
Stay tuned for the breast cancer session when we talk about the positive trial that came out of your institution looking at allowing women with breast cancer to get pregnant and then go back on hormonal therapy.
Yeah.
All right, let's talk about the data again. In this topic, not too much question about what the big story here is. It's just figuring out what it means.
So I thought I'd use this case, this actual age of the patient I saw, 59-year-old, who presented a couple years ago, and he had symptomatic disease from involvement in the ribs, but also had nodal disease, as you can see on this PET scan at a biopsy that showed classic Hodgkin lymphoma. He had stage 4 disease. It wasn't hugely bulky. If you look at his IPS score, it was a 3 for male, gender, age, and stage 4 disease. So I think currently, pending approval of Nivo-AVD, this is sort of what our options are. In the US, we use a lot of BV-AVD based on both a PFS and an overall survival benefit. The 6-year PFS with BV-AVD is 82%. The major toxicity here is neuropathy when you're giving vinblastine and BV together. This can be very problematic, particularly in our older patients. In Europe, escalated BIACOP has been the standard for a long time, using PET-adapted 4 cycles for the majority of patients. The outcomes are very favorable at 91% at 5 years. We tend not to use it here because of the concern for infertility and stem cell damage. How much is that an issue when you're only giving 4 cycles? Maybe less, but really has not been used significantly in the US. And then in the pediatric realm, they're using BV plus their own anthracycline-based regimen, AVEPC. This was published in the New England Journal with or without brentuximab, with very good 3-year PFS. However, about 50% of the patients received radiotherapy. It was given for slow response on PET2, as well as patients who had significant mediastinal disease. So this is the study we're referring to, S1826, very straightforward study, advanced stage Hodgkin lymphoma, Nivo-AVD versus BV-AVD, patients 12 and older. This was really a remarkable collaboration between the Children's Oncology group and the North American adult groups. These are the baseline characteristics, nearly 500 patients in each arm. I will point out the race data here really is quite remarkable for a clinical trial in the US, and I think this reflects our pediatric colleagues who really enroll very broadly in terms of ethnicity. You can see the majority had stage 4 disease, a significant percentage had bulky disease. So this was really representative of the patients that we see with Hodgkin lymphoma. This was the 1-year PFS, 94 versus 86%, presented at ASCO last year. The rumor is that we're going to be seeing a publication soon. I think the data is coming in, so hopefully this will be published in the next few months. In terms of toxicity, I think this is really important. When you give BV-AVD, you have to give growth factor because we know there's an increased risk of febrile neutropenia. It was required per protocol. Nivo-AVD, just like with ABVD or the Rathel approach, you do not need growth factor. The risk of febrile neutropenia is very low, and you can see about half of patients received it. In the study, the rates of febrile neutropenia were higher with BV-AVD, though essentially similar. Thyroid dysfunction, not surprisingly, with the nivolumab, that was the major difference between the 2 arms. Peripheral neuropathy, significantly different. And you can see 22% of patients discontinue brentuximab on the study compared to 11% with nivolumab. So this data that's been alluded to by Matt and others was presented at ASH by Sarah Rutherford. This was the older patients. You can see the number of patients is small. It's only about 50 per arm. I think a lot of us were not referring our older patients to participate in this study because we know that BV-AVD is not well tolerated and probably not of benefit in patients compared to a Rathel approach in older patients. But you can see here the 1-year PFS is dramatically different, 93 versus 64%. There were fewer deaths. This did not meet statistical significance, though really pretty impressive data here. If you look at the causes of death for patients on this study, you can see significantly higher rates of infection, sepsis in the brentuximab arm. So the non-relapse mortality was 4% versus 14%. So this is going to be where the debates are going to happen. We're going to see this a lot moving forward, I think. What's better, Nivo-AVD versus BRCAD? So this is the German Hodgkin study group, HD21. This was a study that had co-primary endpoints in terms of toxicity and treatment-related morbidity, as well as a non-inferiority design for efficacy. Patients did PET-directed therapy and got 4 cycles of therapy if they were PET negative, and 6 cycles of therapy if they were PET positive. The toxicity data was presented at ASH in 2022, and you can see in the box there was a significantly improved toxicity profile with BRCAD versus Biacop. And this was presented at ICML, looking at the progression-free survival, and these curves are impressive. This is a very large study, over 700 patients in each arm, 94.9% with BRCAD, with 4, and the majority of patients got 4 cycles. So this is going to be the question, very well, better tolerated than escalated Biacop, but it is a brentuximab-containing regimen. So what about giving everything? And we saw this at ASH, adding nivolumab plus brentuximab with adriamycin and dacarbazine. This is a phase 2 study, and you can see the PFS at 24 months was 88%. The toxicity was as one would expect with this checkpoint inhibitor-containing regimen. So going back to our patient, he got BV-AVD. He was treated a couple of years ago, 59 years old. This was tough. He had a lot of peripheral neuropathy, a lot of GI toxicity. He did not tolerate Neulasta. We had to give him, short courses of GCSF. He did achieve a complete remission and remains in remission, though if I saw this patient today, I would be offering Nivo-AVD if I could get it. It is 2B in the NCCN guidelines, so I think sometimes that can help you get approval, and we've had fairly good luck getting it approved in our patients. So future directions in terms of advanced stage Hodgkin, chemotherapy works in this disease, and we've seen that for many decades. So I think we're probably going to need some chemotherapy. When you look at PD-1 plus brentuximab alone, in older patients, the outcomes, the CR rate is good, but the durability isn't great. So I think the question is Nivo-AVD, BV-Nivo-AD, or BRCAD. Those are options that all are going to be associated with very high PFS. Cost is going to be a significant player here. And I think the question is, who really needs all this therapy? And using newer ways of looking at PET scans, looking at changes in total metabolic tumor volume, or looking at circulating tumor DNA, hopefully will help guide us. So what about early stage Hodgkin lymphoma? I think currently we're using ABVD-based chemotherapy and then using a PET to personalize the use of radiotherapy and the number of cycles. There have been a lot of studies that I'll show you, a few of them here, looking at incorporating novel drugs. This was recently published and I think is a really important study. This was the H10 study from Europe where patients were randomized. Favorable patients got 3 cycles of ABVD plus RT versus 4 cycles of ABVD. At 10 years, there's a 15% difference in PFS, and I think that is really significant. And I think we have to, yes, we really want to avoid radiotherapy in these young patients, but if you only give 4 cycles, the PFS is significantly different. Interestingly, in the curve on the other side, these are the unfavorable patients who got 6 cycles of ABVD versus, these are the PET negative patients only, versus 4 plus RT, and those curves are not statistically significantly different. If you look at the PET positive patients, about 20% of patients, these were Doble 3 through 5, there is not now a statistically significant difference in escalating them to be a COP. So that's sort of our benchmark, that study. This was a study from Memorial adding BV-AVD to patients with early unfavorable. Patients were then treated in 4 cohorts if they were PET4 negative, and there was no difference in progression-free survival with reducing doses of radiation and reducing fields, and then with no radiotherapy at all. I just put this in here. The Germans have historically used radiotherapy in all of their early-stage Hodgkin patients. If you use nivolumab plus AVD here, either sequentially or in combination, you can see really amazing outcomes, but all of these patients got 30 gray of radiotherapy. This study was presented at ASH this year, and this is what if we give BV, Nivo, AD in early stage patients, they do extremely well. So I think this study, I think we're going to learn a lot from. This is a very complicated schema here. This is run by the Children's Oncology group, but includes all of the US group, very large randomized study. Patients are assigned therapy versus according to favorable versus unfavorable according to those ERTC schema, and then are randomized to standard of care versus BV-Nivo-based therapy. So if you're PET negative, you'll get either 4 cycles total of ABVD versus switching to BV-Nivo for 4 cycles if you're PET negative. If you're PET positive, you get escalated BA-COP versus BV-Nivo. Both sets of patients get RT. The unfavorable, it just includes additional chemotherapy, 4 cycles of AVD for those who are PET2 negative in the control arm. So there's a lot of really good correlatives that are going to come out of this trial, including circulating tumor DNA, financial toxicity, patient-reported outcomes. So this is up and running. Very ambitious study, but I think with the pediatricians who put all their patients on study, hopefully we'll be able to accrue this in the next few years.
And actually, Swati, who's always in our chat room but came here to the meeting, asked the question about early stage disease. We did a webinar with Andy Evans and Sonny Smith where they explained this trial, and we did pre and post testing on the audience. They spent 5 minutes explaining the trial, and 90% of the people had not heard of the study, and 80% of the people watched the webinar said, I would put a patient on that study once they understood it.
Yes.
So it's just, really getting the word out there. One other thing, Jasmine in the audience here says, just a comment. I enrolled a patient on S1826, 32-year-old stage 4 Hodgkin disease liver mets. I offered her fertility preservation. She declined as she has bulky disease, both sides of the diaphragm. No bone marrow involvement, though. Randomized to NAVD, CR, waited a couple years, had her son Leo, 10/31/22, send her a holiday card with her family this year. So I guess it does happen. So let's go on to diffuse large B-cell. And Andy Zanetta was telling me, I was saying, do you have any patients who you've started on treatment of diffuse large B-cell? She said, yeah, 78-year-old. So tell Andy about your patient, see how he would treat this patient up front.
Sure. So this is a 78-year-old who presented with abdominal pain and constipation. We did a PET scan on her, and she had diffuse omental metastasis. We actually thought it was an ovarian cancer or some GYN malignancy. We did a biopsy, and it took longer than we thought to come back because everyone was confused. It came back diffuse large B-cell lymphoma, no double hit. It was non-germinal center origin. She had great performance status. I put her on Polar chip, and all was well with the world. I mean, she had beautiful response. She actually did well with the regimen. And 3 months later, she relapsed. And it was a terrible relapse. She actually had a rectal mass that caused a near obstruction. The radiologist called me late on a Friday night and said, you may want to put her in the hospital. So I called her, I said, start some steroids. If you feel bad, go to the hospital. And I started her on salvage therapy with Rituxan Gemcarbo, just because I could get it in her, within a couple of days. But I referred her to Moffitt, and actually she is undergoing evaluation for CAR-T.
Andy, any thoughts about the case, reflecting back on initial therapy and on relapse and this terrible situation?
I would have done exactly the same thing. This patient has a non-germinal central large cell lymphoma. The subset analysis from POLARIX shows that virtually all of the benefit is in the non-GCB cases. There's some dark zone signature benefit, but you can't measure dark zone signature, so it's hard to find those patients.
Before you go on, we've been hearing about this for a long time, and then just recently, Matt, somebody on one of our webinars questioned the accuracy of cell of origin studies in the community or in general, which I hadn't heard about. Is that a reality? That's the challenge, actually defining cell of origin?
I think it still is. I mean, it's a 1%, 99% question, right? So in the trials, you can do gene expression profiling. You can get your kind of cell of origin based upon that. You go to the 99% and you're getting Hans or Choi-based IHC. So yes, I agree with Dr. Zelenetz. Those curves are darn impressive when you look at GCB, non-GCB. But I ask us more of a societal question, right? 20 years it took for randomized trials going up against R-CHOP. And we were hopeful, and then disappointed numerous times. We finally have a trial which was designed with its primary endpoint. Yes, it was PFS. It wasn't overall survival. Yes, R-CHOP always outperforms itself in clinical trials. But here we have a frontline trial. It was a positive trial, all comers. The toxicity, as you alluded to, you can't tell the difference. This was a randomized double-blinded trial, and you cannot tell when it's polatuzumab or vincristine. What's the better drug? Who's given vincristine monotherapy in relapsed refractory large cell lymphoma? Anybody? Who's given polatuzumab single agent in relapsed large cell lymphoma as a bridge to large cell lymphoma? I have. I've seen stable disease. I think it has, I just think inherently it's a better drug. And what's different about this trial is that the toxicity was not seen with that novel agent addition.
Andy, going back to this case, any predictors? I mean, when I heard this case about this patient relapsing after 3 months, I was like, what's the biology here? Any thoughts about whether we can predict this?
So unfortunately, the short answer is no. You can go into the genomics and look at, if there are poor risk features, but the reality is that there is a proportion of these patients who are going to have early relapse. These were all the patients who were included on the 3 randomized studies of CAR T-cell in second line, all the relapsers within 12 months, and I'm sure Cami is going to discuss these. So, this happens, and the approach is exactly right. Get onto some effective second-line treatment as quickly as possible and prepare for CAR T-cell.
So I'll be interested to see what happens with this patient. How about your patient, Cami, this 54-year-old woman?
Yeah, so this is a 54-year-old, otherwise healthy lady who presented with symptomatic disease, was found to have stage 4 aggressive B-cell lymphoma with rearrangements of c-MYC and BCL2 by FISH, so the quote-unquote double-hit lymphoma. She was treated with 6 cycles of dose-adjusted R-EPOCH. She tolerated treatment well. Interim and end of treatment PET scans consistent with complete metabolic response. First routine follow-up appointment was doing well, but then presented on scheduled with a symptomatic inguinal node. PET scan and biopsy confirmed relapse disease. She had some other disease, but it was mostly that inguinal node that was symptomatic. She got some pulse dex and then underwent leukapheresis for the Axicell product. While the product was being manufactured, she received radiation to that bulky inguinal node, received her Axicell infusion, had grade 2 CRS, got tocilizumab, recovered, no neurotoxicity, but unfortunately on day 30, PET showed a partial response, but then that was followed by progression, and we are now in discussion on clinical trial versus one of the 2 approved bispecific antibodies.
And what do we know about responsiveness of double-hit lymphoma to CAR T?
So it seems as though these patients can do well. It's not, I haven't seen it called out as an independent predictor of bad outcomes, but I think you definitely worry about a patient like this. We know CAR T is very effective, but it's still the majority of patients who are going to relapse.
Also curious, Matt, how often nowadays are we seeing neurologic issues, ICANS, with CAR T and diffuse large B-cell?
Well, I think it's a product specific, and I think it's management specific. I think with regards to Lysocell, it's less common. Not all ICANS is created equal, right? And I think that when I'm giving cellular therapy, what am I trying to avoid? I'm trying to avoid grade 3-4 ICANS. That is the quality of life changing event. Grade 1, 2, they don't remember it. It scares the family. If you talk to them about it, you can talk to your blue in the face about what ICANS looks like, but it is scary. The patient doesn't remember. The family is scarred. Right? That is what it is. So I talk through that, and I'm very aggressive. I think we've adopted Zuma 1 cohort 6 for all CD28 co-stim, so that's Axicell, Brexicell. To help reduce, not CRS, but the ICANS. Every little squeeze of that grape, I think, is important with regarding to reduce the odds of having grade 3-4 ICANS.
What's the typical recovery once you do get grade 3-4?
I think that it depends, it's age dependent. I think my 30, 40-year-olds bounce back. It's definitely a prolonged length of stay compared to what I would expect. My advanced age patients, they are going to acute rehab, and it is something that I discuss with patients in their 50s, 60s, and 70s about ICANS may wind them up in an acute rehab trying to recover from not their lymphoma, but from that ICANS event.
What's your vision of the pathophysiology of ICANS? I never really understood it. You think it's the cytokines or something?
Yeah, I think it is the cytokines do leak into the cerebrospinal fluid. It is it's difficult to control. It's horse out of the barn type of approaches, and I think we've learned to be very aggressive. I mean, there are anakinra studies going on right now to use it prophylactically. In this situation, and we actually, it's kind of an all hands on deck type of approach. And I do think that the durability or the temporal nature of the amount of time you're spent in that grade 3-4 ICANS event does matter, right? So if you can shorten that event and get it back to grade 1, grade 2 very quickly with your therapies, that matters from how long the long-term side effects. These are all nuances that live outside of the clinical trials. We are so much better at managing CRS. We are better, not so much better, we are better at ICANS, but that, this is, why you do it in select centers.
Really interesting. All right, Cami, let's talk about the data. We're talking about the POLARIX trial. Here it is.
Yeah, so, the large majority of progress we've made in large cell lymphoma in the past 5 years has been in the relapsed refractory setting. But as Matt alluded to, about a year ago, we saw the first approval in the frontline setting after over 20 years of trying to move that field forward. And this came with the approval of the CD79 antibody drug conjugate polatuzumab, based on the POLARIX trial, which was an international randomized phase 3 trial looking at standard of care R-CHOP versus Pola-R-CHIP. And patients with stage 2 to 4 disease, IPI of 2 or higher, were randomized on this trial. This was a positive trial, about a 6.5% improvement in the 2-year progression-free survival with the addition of polatuzumab, from 70 to 76.7%. And at 3 years of follow-up, the 3-year PFS was about 7.5% benefit. There was at 2 or 3 years not an overall survival benefit at this time. So as also, I think Andy alluded to, the pre-planned subgroup analysis from the POLARIX trial suggested that certain patients benefit more from the addition of POLA, including patients over 60, patients with IPI of 3 to 5, and then those patients with ABC subtype diffuse large B-cell lymphoma. As Matt alluded to, looking at the toxicity profiles of these different regimens, they were actually fairly similar. Peripheral neuropathy was almost exactly the same. There was some difference, and I do feel like I see this in practice, a higher rate of diarrhea with the polatuzumab R-CHIP arm. And there was a higher rate of febrile neutropenia, although this didn't translate into a more dose reductions or dose continuations from therapy. I'm going to pivot to relapse refractory setting. We have 3 autologous CD19 chimeric antigen receptor T cell therapies approved in 3rd or later line relapse refractory large cell lymphoma, axicell, lysocell, and tezacell. And all these have been studied in randomized trials in the high-risk patients. So patients with high-risk large cell lymphoma are really those who are considered to have refractory disease or relapse within 12 months of therapy. They have overall survivals of only about 6 months. So these trials were all randomized phase 3 trials that took and randomized patients to the CAR T cell product. The Zuma-7 was axicell, transformed lysocell, and Belinda the tezacell product, to standard of care salvage chemotherapy or autologous stem cell transplant. This table just shows some of the differences in these trials, but 2 out of these 3 trials were positive. So the Zuma-7 and transform trials were positive, leading to a change in the standard treatment approach for patients who are refractory or have early relapse to treating them with CAR T cell therapy in the second-line setting. This shows a primary endpoint EFS of the Zuma-7 trial, a statistically significant benefit in EFS with a 2-year EFS of 40 versus 16 CAR T cell versus standard of care therapy. I think, there was an improvement in all other efficacy outcomes, really the safety, which has been alluded to by everyone on the panel. There is a difference between these products from a safety standpoint. The grade 3 or higher CRS seen in this trial with axicell was 6%, and grade 3 or higher neurotoxicity was 21%. This trial with longer follow-up did show an overall survival benefit, so median overall survival of 31 months with standard of care versus not reached with that of axicell. Of note, there were patient-related outcomes studied on the trial, and axicell was associated with an improved quality of life as well. The second product that's approved in the second line setting is the Lysocell product. Again, this primary endpoint of this trial was event-free survival, and this was statistically significant improvement in event-free survival, 2 versus 10 months with the Lysocell product. Looking at this more recently, overall survival with longer follow-up has been shown to be not reached. Safety of this product, so as has been discussed, this does appear to be a safe product, so any grade CRS 49 versus 92%, with only 1% grade 3 or higher CRS, and only 4% grade 3 or higher neurotoxicity. This agent is also approved in the setting of second-line patients who have later relapses but are not considered candidates for standard therapies. So the next kind of exciting agents in this setting, the bispecific antibodies. So the bispecific antibodies in large cell lymphoma target CD20 by CD3. We currently have 2 approved. They were approved within a month of each other, epcoritamab and glofitamab. Epcoritamab approved based on the EPCOR NHL-1 study. I'll just note this was evaluated in patients with 2 or more prior lines of therapy with aggressive B-cell lymphomas. Epcoritamab is a subcutaneous treatment. It is given at step-up dosing during cycle 1, and the first 3 cycles are a weekly treatment. Then it goes to bi-weekly up to cycle 9, and then every 4 weeks from cycle 10 on. And this treatment currently is approved to be given until progression. Highly effective therapy in the relapsed refractory setting with overall response rate over 60% and CR close to 40%. There were patients who had received prior CAR T-cell treated on this trial where the complete response was similar to that of seen in the entire population of patients. If you look at that cohort of patients who achieve a CR, median progression-free survival and overall survival at current follow-up have not been reached. So patients who achieve a CR with this do seem to get fairly durable remissions. Looking at toxicity, most common toxicities, CRS and neutropenia. CRS with epcoritamab is, in general, very predictable. Over half of the patients got CRS, 51%, but the majority was grade 1, although as Andy did discuss before, you do see some grade 2 CRS with EPCO as well. This mostly occurs after the maximum dose is given on day 15, and it currently is recommended to be hospitalized for 24 hours after that dose to monitor for CRS. Not on here, but something I think we see a lot in practice is infections, particularly viral infections, and I've had a number of patients who it's really difficult to clear those kind of rhinovirus, just regular viral infections. Glofitamab is the other bispecific approved in relapsed refractory large cell lymphoma. Similar population of patients. Primary endpoint of this trial was CR. Differences here, this is an IV instead of sub-Q treatment. This patients receive obinutuzumab on day 1 to reduce the risk of CRS, and then they're given IV treatment weekly up until cycle 12, at which time it's discontinued therapy. A similar overall response rate in CR to that seen with epcoritamab, really. And again, in the population of patients who had received this therapy after CAR T cells, complete response rate was very similar, similar to the epcoritamab for those patients who achieve a CR. Median progression-free survival and overall survivals are prolonged. Like EPCO, the most common toxicity is CRS with glofitamab. It's also more predictable, maybe not so much as EPCO, but the highest, 63% of patients had CRS, mostly again grade 1, but you do see a little bit of 2, 3, and 4 CRS with glofitamab. The majority of patients are going to get it on day 8 of treatment, which is the first dosing of glofitamab, and it's recommended that patients are hospitalized for 24 hours after that dose, and then actually continue to be hospitalized if they have CRS. Loncastuximab is a CD19 antibody drug conjugate that's approved in relapsed refractory large cell lymphoma. This was based on the LOTUS-2 study. Lonca is an IV infusion that's given every 3 weeks. It's given at a higher dose for the first 2 cycles and then a lower dose after that. This trial enrolled fairly refractory patients with high-risk disease features. About half of them responded, with 24% of them achieving a CR. For those patients who achieve a CR with Lonca, the responses can be durable, with close to half of the patients maintaining that response over a year, and about a third of patients maintaining their CR for greater than 2 years, with most common toxicity being GGT abnormalities and cytopenias.
Quick question to Ann, have you used Lonca T?
I've used it predominantly before we had the bispecifics available, but it can be relatively well tolerated if you give, the steroids, I think, mitigate the volume overload issues, and it is good for, a frailer patient, I think, can sometimes tolerate this quite well.
Thanks.
And then the last agent I'll mention, odronextamab, which is a CD20 antibody that's showing, bispecific antibody that's showing activity in relapsed refractory large cell lymphoma, but is not yet approved. This is also IV. This is given continuously, and it has a little more intense schedule with day 1, 2, 8, 9, and 15, 16. Initiation, and then every week, and then it goes from every 2 weeks until patients achieve a CR. Then they can go every 4 weeks. Very similar overall response, complete response rate to that which seen with the other ones, and a similar rate of CRS, which is mostly grade 1 or 2. Again, this is still not approved, but has also been studied in a population of patients post-CAR, showing very similar results to that in the population of patients who've not been exposed to CAR.
So we're going to take a quick break. I was just thinking, we actually did 2 programs at the Society of Gynecologic Oncology meeting on Monday, and we're about to do GYN again. So I've got it fresh in my mind. This is a great session. Zanetta, thank you so much. Faculty, thank you so much. We're going to take a quick break.